Center for Healthy Sex in Los Angeles presents a lecture by Ellen Heed, What to Do About Scars, Sexological Bodywork, and Scar Tissue Remediation.
So before we get started, I want to just a quick little interaction with y'all to find out what drew you to this lecture. Because everyone has a reason for coming, what the heck is sexological bodywork and why do I care about scar tissue? What's its relationship to sexuality? If I just want to hear from you why you came, just like 3 or 4 words. The CEUs is fine, if that's true for you. Or if there's something in particular you want to know about it, then I can kind of drop that information in to the presentation as I move through the material today. So why don't we start over here and we'll just go kind of snaking back and forth all the way to the back row.
I thought it was a very interesting topic, first of all, and second for the CEU.
Okay, cool, thank you.
You're welcome.
Yeah, as a therapist in Arizona, I worked at a place that specializes in sex addiction, so all things related and other good things. This place has a great reputation.
Mm-hmm.
Glad to be here. CEU.
Yeah, cool.
I'm a pain psychologist, and more and more seeing people who are transgender or having gender-conforming surgery, and wanted to know more about it.
Excellent. Thank you. That's helpful because I can drop in more information about that into the lecture because that's becoming more and more prevalent as a problem for people who are dealing with the surgical aftermath of transgender, making transition from one gender to another. Yeah.
I'm just trying to get back into my role as a therapist, so I'm really trying to get more involved in this aspect of it. But also I have a background with physiology, so I want to be able to see at least where I can start to use that and if it's something I kind of want to.
Cool. Great. Thank you.
I've been studying human sexuality since I was an undergrad, and I just love the topic. And I do also want to know more about transgender surgeries and how it affects their sexual being. And so.
Yeah. There's some very particular issues that transgender people are dealing with in terms of.
Close to me who's starting transition, so I also just want to know more and support them.
Great. Cool. Thanks. So I'm just asking people to say why they came.
Okay. Well, because I work here. So. But I also have a background in body work. I've studied with some of the people that Ellen studied with, and I've always looked up to your work, but it's been years. So I was really excited, and I saw that you were coming, so I'm just excited. That's it.
My name is Michelle. I just recently graduated from my MSW program, and I think human sexuality is a very interesting topic, and especially in my community, no one talks about it. It's very hush-hush, and it is something that people struggle with, especially married couples. And I do want to especially.
So scar tissue is so integral to work with married couples because it happens frequently as an outcome of childbirth, and nobody talks about that, regardless of their community, culturally.
A lot of women are saying we're not going to have natural childbirths because we want it to remain the same.
Guess what?
Yeah.
Yeah, that's a myth.
Exactly.
We're going to bust that one today.
It's a huge trend right now.
Yeah. So it's good for everyone to have this information so you can tell the truth because statistically, a C-section has just as many scar tissue sequelae, after effects, as vaginal birth or episiotomy. You don't save yourself anything by getting, in terms of sexual outcomes in the long run, through choosing a C-section. So, just saying, not going to help. Well, thank you for bringing it up. Yes?
I also just started working here, but I worked for someone that used to study under as well. So
Dr. M.
yes.
Yeah, cool. Yeah.
So I just wanted to see what kind of work has evolved.
If it weren't for him, I wouldn't be here.
Likewise.
Yeah, he's very big on scar tissue, and he basically picked me up from where I was and said, after you learn to do body work, you're going to do this because this is your destiny, and he's got the vision to be able to say, I can't do this work. I'm not a female. You can do this work. You go do it. And I'm like, okay. So here I am. Yeah.
Most of my background is in nutrition, and I was working with some of his clients But I'm just fascinated with the body in general. I like to see what's involved in it.
Cool. So some of this will be very familiar to you. Yeah.
Hi, I'm Lauren. I'm in an MFT program right now. I am interested in focusing in pre and postnatal.
Mm-hmm.
And I just had a baby myself, so I'm very familiar with this territory.
Okay, cool. Great.
Hello, I'm Claire. I read your bio, and I was a massage therapist for 10 years, and then I did a master's in somatic psychology.
Mm-hmm.
Very interested in trauma, intersection of trauma and sexuality,
Mm-hmm.
and was like, I want to know more from her.
Yeah, good. Because that's what I do. The intersection of trauma and sexuality.
Yeah.
It's like,
And also the childbirth piece. So many of my friends who've had children have been in pain for a year after childbirth, and it seems like there's no solution, and so I was drawn to this.
great. Yeah, we're going to talk about solutions today. Yeah, because there are. It's just they're a little out of the box for most people. Or, God, help me, in the box. Sorry.
I am Kana. I have a private practice in Venice, and I specialize in working with women who have pelvic pain, chronic pelvic pain issues. So I have a women's group for that.
Mm-hmm.
And then I'm also trauma trained, so I also do the intersection of trauma and sexuality, helping heal that. I also am a lot of the work that I do is focused on body work as well. Yoga, acro yoga. I'm starting to create a trauma treatment with acro yoga involved.
Fantastic.
So all of your things, I was like, yes, get me there. So I'm
Excellent.
excited.
Do you know Lara Catone? Yeah, I thought you might.
Yeah, she's a good friend of a dear friend of mine.
Uh-huh. Yeah.
Paradoxical.
Yeah, great. Thanks.
Hi, I'm Karen. I'm a friend of Allison Macy's,
Ah.
and I've been hearing Ellen Says for about a year now. I'm here for a couple different reasons. Personally, I'm very interested anything to do with postpartum sexual receptivity and how scar tissue may or may not be affecting that. And professionally, I'm a healer, and I work with a lot of trauma, and I'm not sure I would work with this directly, but I want to know about it. I'm a throwaway a lot of times as
Yes.
a girl, so I'd love to know what's possible.
Yeah, it's really good to get an idea of who's available to do this work in the community because there aren't that many of us. And we're busy. And the more people you know about, the more likely you are to end up with a referral that's going to bear fruit. So, yeah, great.
Hello, I'm Tammy. I'm just fascinated with human sexuality, and I'm just here to learn whatever.
Thank you. Thank you so much. This will help me help you. So let's start with the scars. Let's first talk just a bit about sexological bodywork. Sexological bodywork enables, it's a certification, and in the state of California, and this is different than every other state in the country, so California is special in this regard. California allows sexological body workers to touch genitals for money legally. That's sort of the most compact definition of what scope of practice includes for sexological body work. In other words, for purposes of education, I can do a process that's called mapping. Mapping means, for me, an anatomy lesson that's embodied. Here's your outer lips, here are your inner lips, here's the clitoris, here's the hood of your clitoris. Did you know that can retract? Oh, you didn't know it could retract. Oh, it can't retract because there's a scar there. That scar came from what? Oh, that scar came from your childbirth. Okay, so you haven't had the same kind of clitoral sensation that you used to have since your childbirth. Let's see what we can do about that. So that's a segue from information into hands-on therapy. Hands-on therapy that's tied to education. The education that includes, oh, there's a scar. That scar is preventing sensation that used to be available to you. Can we do something about that scar? And then drilling down to the personal, can you, the client, do something about that scar? Because there's always something the client can do. They can do self-massage. They can apply castor oil. They can literally start to peel apart the adhesions where one tissue is glued to another. But they wouldn't know how, and they wouldn't know that they could, and they wouldn't know that there are active ways to do this, passive ways to do this, and ways that are enhanced by working with another person. So sometimes they can engage their partner to help with application of castor oil if they can't quite reach the areas that are impacted by scar tissue. Or sometimes they want to come to somebody who actually really knows the territory, who's not a PT. Because physical therapy, although it's very effective, isn't really arousal based. And functionally, sexological body workers, that's what we do. We teach people about their own arousal possibilities. That is part of the educational aspect of what we do. It's like, oh, on a scale of 1 to 10, how's your sensation? Oh, you can't feel that. And you used to have feeling there. All right, let's find out why. Is it because there's a scar that's impinging a nerve? Or is there a scar that's preventing lubrication from rising from the cells up to the surface of what's supposed to be a lubricated mucosal membrane? The slippery bits aren't slippery anymore. And that causes pain. Pain when? Pain on penetration, pain on contact. You don't want to have sex anymore. Now your relationship is starting to shift because you're not available for arousal. How can we change that? By making it safe for you to explore and find out where those pain places are, teach you ways you can heal your own pain. And if you can't quite get to those places, we can get to them together because of my orientation and abilities to work internally. I can link you back to your arousal in a way that's very helpful, in a way that's going to resolve that sexual pain, in a way that's going to return you to the ability to lubricate postpartum. Oh, you didn't know that because you're breastfeeding, you're not able to lubricate. Well, that's a piece of information that's really important, that breastfeeding actually changes your hormonal balance, and now lubrication isn't even available. You're in a mini menopause while you are breastfeeding. Women don't know that, and they wonder why they have such disinterest in sex. And then when the breastfeeding period is over, things tend to normalize again. But a lot of women never get that information, and they wonder why they're distancing themselves from their husband while they're attaching to their infant, and that's how it's supposed to be, not the distancing part from the husband, but the focus needs to be on the infant. So prolactin, which makes the breast milk come down, also inhibits sexual response cycles. And women need to understand that so they don't think there's something wrong with them for wanting to attach to their baby and having a distinct disinterest from their husband for the period in the immediate postpartum. So we provide education hands-on, hands-in, and also pragmatically, because this is part of our training. We spend a lot of time studying human arousal, a lot of time practicing arousal with ourselves, with other people, with every gender configuration that's available in the context of any one training, and really understanding the variety of human sexual response and what erotic possibility actually means. So we can then talk to people about where they're stuck in their own erotic trajectory. That's a little bit about sexological bodywork. There's sexological bodywork trainings all over the world now. There's one in California, which is the only one in the United States. Canada, the UK, Australia, Czech Republic, Brazil, Spain, occasionally in Scandinavia. These are, and in Germany, these are all countries where there's sexological bodywork trainings now. So it's starting to, the network of sexological bodyworkers is beginning to grow. There's about maybe 300 to 400 sexological bodyworkers all over the world presently. And quite a number of them in Los Angeles. There are about 25 practicing sexological bodyworkers in the metro LA area presently. All right, so when we talk about sexuality, we have to look at what I call the 4 essential domains of health, meaning those of you who are familiar with Dr. Medici and his work, he called this the rule of 4. I'm writing a doctoral dissertation about scar tissue and sexual healing that looks at sexual health through these domains. These domains include nutrition, and a bigger name for that is biochemistry. What affects the blood chemistry of any given person? If a person is hormonally changed up because they're breastfeeding, hormonally changed up because they're postmenopausal, hormonally changed up because they're deficient as a result of lack of nutrition while they were pregnant and not ever getting the essentials back into their diet postpartum to make hormone. That's a nutritional aspect of health. People are posturally deranged, often after pregnancy. I was just working with a woman yesterday who was just 3 months postpartum, and she's a yoga teacher, and I knew her before, and her posture was like this. After she had her baby, her posture is like this, because her psoas has changed configuration because of the weight of the baby as it developed, and she's still carrying quite a lot of weight from her pregnancy. But it's not the weight from her pregnancy, it's the fluids that are unable to drain. Why? Because her psoas, the muscle that is kind of the muscle that's underneath her guts, is literally pushing them forward and causing a problem with drainage here at the break of the leg. So she's carrying all this weight in her belly. She's breastfeeding, so her breasts are engorged with milk. And it's creating a situation that's pushing her organs out of her pelvic floor, and she's starting to have some prolapse issues. So we have to understand that prolapse is related to posture. The minute that psoas goes into place and her weight comes back onto her heels and her guts have a place to land in her pelvic bowl instead of pushed out of her pelvic bowl, now her urinary bladder has a place to sit where it's supposed to be instead of getting knocked out of place, so it has no place to go but down. So yesterday I didn't work on pushing her bladder back into place, which I will on our next session. I worked on building a network of strength and integrity in the muscles of her pelvic floor, working with exercises that we do on the wall, and then manipulated her psoas back into place. So now her bladder has a place to drop and be lifted into as she starts to strengthen her pelvic floor again. So this is kind of a physical therapy type approach, but physical therapists aren't going to then link that to, oh, well, there's also this problem with my sexuality, and I don't really want my husband anywhere near me right now, and that whole conversation because she's breastfeeding. So we're having an inclusive approach, so working with the biomechanics is going to be key for her to actually give her organs a place to be where they're not getting pulled down by gravity and getting pushed down by her post-pregnancy posture. Emotions. Most of you in here seem to have a background in psychology, so emotions are you're no stranger to the notion of emotion. Emotion lives in the body, from my point of view, as tension in particular muscles of the body. The psoas is a muscle that carries emotional tension. The scalenes are muscles that carry emotional tension. The erectors along the spine are muscles that carry emotional tension. And when we're tight in these muscles, it affects nerve flow. It affects our ability to breathe. If it affects our ability to breathe, it affects our ability to feel. If we're internalizing emotions and holding that tension deep in the gut, in the diaphragm, in the psoas, in the pelvic floor, it's going to literally compress the nerves that feed the genitals and will be blocked from sensation because of this internalized emotional tension. So working with the emotions to get them up and out of the tissue from unconscious, like I know those emotions are there, but I don't know how to get to them. Well, I do. I know exactly how to get to them. Through a process, a very titrated, carefully titrated process of palpation and seeing what happens. And then provocation after palpation to see what wants to come up that's being suppressed, and then allowing just enough emotion to come up to acknowledge that it's there, and then finding out what's going on, what's the story underneath that emotion. Does the story include a traumatic birth? Does the story include a sexual molestation incident? Does the story include some kind of lack of information so people are kind of frozen in time around not feeling empowered in their sexuality? So working with the emotional body is key to opening up that pathway for sexual expression, because emotions are held as tension. Tension will compress nerves. If the nerves don't flow, then we're missing sensation that would otherwise be available.
When you say palpation, you mean physically?
Physically.
On the body?
That's right. That's right. Yeah, you may have seen this in action somewhere along the line if you were studying with Dr. M et al. He was big at doing body work and doing this provocative style of palpation in particular muscle groups, the psoas, the scalenes, the pecs, the erectors, sometimes the piriformis at the back of the body. These are all muscles that have discrete emotional content, from my perspective, that you can find a lot out about your client, where they're holding and where they're free, but also these muscles tend to compress major nerve groups. And those major nerve groups have a lot to contribute to sexual sensation. Yeah. Then finally, scar tissue. Scar tissue is the great unacknowledged essential domain, meaning it can't be pared down any further than scar. Scar is health. If we have scar tissue, the cell's basic operating system is interfered with. In other words, the cell requires information in and drainage of waste. Information in comes in through chemistry from the blood. It also comes in through nerve impulse, through what's called the ECM, the extracellular matrix. That's the goop around the cells. That goop transmits information from nerve, from blood, and then lymph vessels drain the ECM, the extracellular matrix. The ECM is where scars form. They turn that goopy gel into something solid, hard, and impenetrable. So now information can't get into the cell, and waste can't drain away from the cell, and what that creates is cellular dysfunction. It becomes the very basis for disease, becomes the very basis for a lack of sensation and a lack of a lack of helpful cellular response to environmental cues. So we've partially what sexological body workers do is work with this tissue in the pelvic floor, because 83% of women who give vaginal birth are going to have a tear, an episiotomy, or suturing to repair a tear in their pelvic floor. That's a lot of women who are suffering birth injuries. Those injuries and those sutures leave scar tissue. That scar tissue then blocks the ability of nerve to get to genital tissues as far as sensation. It also blocks the ability of fluid flow, so lubrication can come up from deep tissues to superficial, and also drain again. There's a lot of blood that engorges all of these erectile tissue beds in the female pelvic floor. And those erectile tissue beds can't become erect because the blood can't engorge, because there's a scar in the way of the capillary delivery of blood to the genital. With no engorgement, female sexuality is a symphony and a very deliberately paced series of steps. And when any one of those steps is interrupted, then you don't get the full trajectory of arousal possibility. So people have 30% of their arousal potential available to them, for instance, if they have scars that are literally blocking blood delivery to erectile tissue beds, or blocking the body's ability to lubricate, or blocking the ability of, once you have become engorged in the erectile tissue beds, now the fluid, the venous drainage can't drain, and you're walking around feeling full, heavy, and throbbingly uncomfortable in your pelvic floor because of scars and the inability of venous drainage to carry the blood away and return it to the systemic circulation. Does that make sense? So this is sort of the physiology piece of scars. And scars are eminently workable. Castor oil is scars' worst nightmare. Castor oil changes the viscosity of the ECM. It changes it from being tight, granular, thick, and impenetrable to being workable. How does it do this? It excites your own immune system. It acts as a flag for lymphocytes, says, hey, lymphocytes, come in here and chew through what's extra. Ricinoleic acid is the active ingredient in castor oil. And it's anti-inflammatory, it's analgesic, it's antioxidant, it's antiviral, and it's antibacterial. It's magic stuff. If you use it and apply it to the scar, the uptake through the vaginal mucosa is very, very efficient. It goes right to the scar and starts to dissolve it. It changes the configuration of the scar. Yeah?
Would that also be beneficial for somebody who doesn't necessarily have any scar tissue on the opening of their vulva or vaginal opening, just to use as a way to help with the inflammation of the nerve?
Yes, absolutely, because it's going to calm that inflammation. And there's ways to apply it. Of course, you can just rub it on topically. That's great. But you might also dip a tampon into a bowl of castor oil and insert it and wear it for 20 minutes. not longer than, and not every day. You might wear it every other day or 3 days a week for 20 minutes each time. You don't want to sensitize to the castor oil and then get itchy or burning, which can happen in the mucosal membrane. So 20 minutes every other day, no more than 3 times a week is my limit, because I've had people have the experience of sensitizing to castor oil. That's a very practical thing to do. It's very simple. If women knew about this, I'm sure they would use it in the postpartum period when they're feeling tight, dry, pinchy, painful, and it doesn't cost much. A bottle of castor oil is what, $10? Box tampons, $6. I mean, really, it's simple and available, easy to do. So scar tissue, eminently workable. So people who train with me are looking through each of these lenses simultaneously when they're thinking about pain, pelvic pain, sexual pain, and trying to determine, is it a biochemical problem, is it a postural problem, is it an emotional problem, or is it scar? And when it's scar, the scar needs particular kinds of attention.
Castor oil, does it have any adverse effects at all, like any side effects?
The only adverse effect I've seen has been sensitization. Obviously, or maybe you don't know this, but you would never take castor oil internally except on a very particular, so it's great for topical use. That's a typical way that it's used. It's used to bring on labor if you take it internally because it excites smooth muscle. Exciting smooth muscle is not something you want to do if you want to avoid attack of diarrhea, right? You don't want to excite the smooth muscle of your gut because you'll know about it. So scar tissue is used in severe cases of constipation, and it's also used when a woman's water has broken, but the contractions haven't started. In order to get the uterus to start to contract, it's a common midwifery tool to use to bring on the contractions if they haven't started after the water breaks. So scars form along connective tissue pathways, and we need to kind of review a little bit about connective tissue if we're really going to understand scars. Connective tissue holds us together, separates, organizes our insides. It supports and protects organs, nerves, and muscle. It also protects each tissue from too much friction with its neighbor, and it is so everywhere in our body. Think of a muscle. You have the muscle and the skin. Underneath the skin is a layer of connective tissue, and then that layer divides the arm into muscle fiber bundles. Each one is a separate muscle. But then within each muscle, there's separate bundles of what's called fascicles. Every fascicle contains muscle cells. Every single muscle cell is surrounded by fascia. Every single muscle cell in your body is wearing a fascial raincoat. Imagine that. Connective tissue rules our system. We think we get flexible by stretching our muscles. No, we get flexible by stretching our connective tissue. The muscles follow along, and they're inhibited by the connective tissue. If the muscle is injured, the connective tissue, by definition, is injured. What that means is muscle fibers that are supposed to slide and glide over each other now don't. They're stuck, and they operate now as 2 or 3 muscle fibers stuck together. And so the use of castor oil starts to break down some of the chemical bonding within the fascia, starts to open it up. That's part of the action of ricinoleic acid within the castor oil. So connective tissue connects. These are individual muscle fibers over here on the upper photograph here. It's an electron micrograph of individual muscle fibers, and the white webby stuff between those is fascia. On the bottom, we see a chunk of human thigh, and you can see the fascial pale separation of the different muscles in the thigh, and of course you can see a little femur bone on the right side of the photograph. We have so much connective tissue in the body. It's everywhere we're soft. Everywhere you push into your belly, into your throat, into your ears, into your arms, there's connective tissue in there, and that connective tissue transmits information. Catch this, this is important, 200 times faster than the nervous system. Connective tissue is sentient. It has intelligence. It's not inert. It is alive, and it holds information. That's big news because we've been taught that connective tissue is not so interesting, not worth our attention. It's that extra stuff to scrape out of the way when you're doing a dissection to get to the important things, the bones, the muscles, the organs, the glands. But all of those tissues are surrounded by connective tissue, and this connective tissue has an important function. It mediates all the information that gets to that gland, that gets to that organ, that gets to that muscle. It has to flow through a connective tissue, either enhancement of communication or barrier to communication. So we want to get right with the connective tissue in the body. And of course, anyone who's done massage in here knows about what massage can do to soften and illuminate and enliven connective tissue, bring it back into its conductive capacity rather than just support. These are examples of different kinds of soft connective tissue in the body. Ligament, here we see a shoulder joint. On the right, we see ligaments holding the bones of the shoulder together. We see tendons that attach the muscles to the bones. And then we can see fascia here on this illustration. The fascia, do you see this edge here? It looks like clear saran wrap. You can actually dig your own hand up under that edge. If you wanted to, you'll feel it kind of burn and stretch as you pull that tissue up away from the armpit and towards your shoulder. You could actually kind of pluck on it like a guitar string, depending on how tight it is. So this is the clavipectoral fascia, this whole sheet, separating the pec major from the pec minor underneath. And we have these fascial sheets that separate layers of muscle throughout the body. If they become scarred, then the muscles, whole muscle groups, no longer slide and glide over each other, then they're stuck, and then we lose range of motion, and we lose our ability to bring fresh blood into muscle, drain waste away from muscle, and then the muscles themselves start to become calcific. They start to become plaqued over. They start to become stiff, and then we lose function. That's what creates what we call aging in terms of posture. When people say, oh, well, I just can't move my shoulders like I used to, it's scar tissue that's accumulated as a result of postural habits, emotional habits, biochemical habits, and then that leads to the creation of scar. So I said this before, but I'll say it again because I don't think you can say it too many times. When you talk about fascia, you have to understand that fascia is sentient. It predates the nervous system in biological evolution by hundreds of millions of years. Even a bacteria has something akin to a fascial structure in its body that gives that bacteria behavior, and that bacteria has no nervous system. Yet it travels towards things it likes, it travels away from things that feel dangerous, it's able to find food, it's able to find mates, and it's able to actually enact behavior as a result of its microtubule connective tissue substructure. So fascia has intelligence, and that intelligence conducts 200 times faster than the nervous system. Fascia surrounds, supports, and penetrates muscles and organs. In the macro view, fascia separates each muscle from its neighbor and separates muscle fibers into bundles, and then the bundles down to individual muscle cells. The micro view, wrapping around each muscle cell and determining cellular behavior according to how healthy the connective tissue or the fascia is. Scars are found everywhere, between skin and bone, between organ and organ, between muscle and muscle, muscle fiber and muscle fiber, in the spaces between the cells. Scars enact as tiny little adhesions to massive amounts of disorganized tissue that constrict range of motion and physiological function. To me, and this is what the subject of my dissertation is, a scar is unresolved traumatic residue. There's an emotional component to a scar that when the emotion that's associated with that scar is processed and comes to consciousness, the scar itself changes shape. It changes physiology, and it instantly dissolves during episodes of emotional, what I call somatic recall. Somatic recall is somebody is talking to you about the weather, and they're talking about their baby, and they're talking about their husband, and then suddenly I'll be mapping their genitals, and we're having this conversation. It's very casual, and whoa, there was this moment, and then the doctor said to me, and I'm right back on the table, and I'm having my baby, and I feel so helpless, and I feel so frightened, and I don't know what's happening. One tear. And wait a minute, I just had my hand on a scar, and that scar is gone. Where's the pain? I don't know. That pain was there a second ago, and it's not there anymore. What just happened? It dissolved. It dissolved because the body made a new choice. So I maintain that a scar is at least half emotion, half a body decision moment to moment to create that adhesive tissue as a way to protect from a memory that the body's not ready to process. Yeah.
So do you think, I mean, you said it released automatic, like right away when she was thinking?
Instantly.
But is that something, I mean, she has to, it's like exercise, you have to keep doing it, keep it in shape?
No. It's gone. Once it's gone, it's gone. If she has fully integrated the emotion, if she's partially integrated the emotion, the scar is going to come back to the degree that the emotion has not been fully integrated.
So just acknowledging that emotion or bringing it to awareness, you're saying?
Yes, that's right. Just bringing the emotion to awareness can change the viscosity of the fascia, change its density and its behavior. Fascia has behavior, and it can change. And it's intimately related to the emotional body. Question?
With palpation.
Yes, during palpation. During palpation. And I maintain that's why this is different than hypnosis or other therapeutic modalities, because it's a connective tissue reality that seems to be driven by physical touch, which is different than processing something more abstractly through the use of language. Yeah, there's a qualitative difference. And, you know, if the tree falls in the forest and no one's there to hear it, did the tree fall? If somebody has an emotional integration and they have a change in their scar tissue, but there was no one there to palpate, how do we know what changed? We may not. So that's why I say this is related to physical palpation. I don't know. Maybe the changes are happening when people have emotional releases, but that's not what I see. I see people who have processed and processed and processed their birth trauma in all kinds of situations, yet they're still having scar tissue pain in their pelvis. Yet we work 1 or 2 times with my hands on the tissue. They have memories that they've never processed before coming up because I believe they're buried in the fascia. And that's when these sort of miraculous shifts start to occur. Yeah, I maintain that it's because the fascia knows something. Yeah. Here are 2 pictures of fascia. This is how we used to understand fascia, dead, inert, and basically looking kind of like petrified wood. No wonder scientists considered it to be an inert tissue because they were only looking at it in preserved bodies. That's very different than the way we understand fascia today. Now we can take tiny endoscopic cameras into living fascia while surgery is being performed, and that's what this picture is on the top. So this is somebody who's getting surgery in their forearm. And this is a picture of the fascia that's covering the muscles, that white kind of gelatinous, shiny, stringy stuff is fascia. And then we can see deeper, denser muscle covering fascia, more tightly wound around the muscle tissue.
Would you say that this is like healthy fascia, or is it like crystallized fluid? Like what would you know?
We're going there.
Oh.
Yes, we're going there. But first, how scars affect sex. Because this is something that, you know, you guys have probably gotten a pretty good idea what my position is about this, but scar tissue transmits strain over a wide, sometimes unpredictable area. You can have a pull from an appendectomy here in the lower right quadrant of the torso and end up with Dowager's hump within 15 years. Why? Because that adhesive patterning has climbed through a connective tissue kinetic chain that goes from the lower right quadrant to the ligament that goes from the bladder to the navel, behind the liver, up into the diaphragm, behind the pericardium, attaching to the anterior longitudinal ligament. Before you know it, you're standing like this, because it's like a pull in a sweater, as we see illustrated in the picture here. That scar changes the viscosity, the flexibility, and the movement potential of the fascia through a particular chain, usually driven by a habit. A habit of, this is how I sit at the computer all day. If I sit at the computer all day and I'm compressing this tissue, how is that tissue going to transmit force that's going to create this kind of scar that basically changes function? Where does it change function? It could change function in the site of the original injury, which could be an episiotomy, a C-section, a sports injury, a molestation memory, all of these kinds of trauma that can be in the pelvic floor. Scars have the ability to change genital movement, genital posturing, genital position, sensation, lubrication, and that creates sexual pain. So genitals become affected by scars. Okay, this gets to your question about how do we know what healthy connective tissue looks like. This is a picture of healthy connective tissue. This is actually a computerized drawing representing healthy connective tissue based on the photography of the surgeon who does the live fascial movie making. His name is Jean-Claude Gimberteau. He's a French hand and arm surgeon. And you can access his work easily on YouTube. If you look for a movie called Strolling Under the Skin, you can see live fascia in healthy bodies, and he talks about how to differentiate healthy fascia. Gimberteau. Oh, Strolling Under the Skin on YouTube. He's also just published a book last year on fascia, and it's amazing because a lot of these images come from his book. This is healthy fascia. You can notice that it's spacious and it has a fractal multiple polyhedron style of shape here. If you look on the right, look at the difference between these thin, stretchy members of the fascial support structure versus thickened, sticky, adhered. Here's a picture of an adhesion right here. See that thick, sticky, shiny material in there? That's going to stick members that should be sliding and gliding freely over each other, stick them together so motion is limited. When motion is limited, lymphatic drainage is limited, blood delivery is limited, nerve delivery is limited, and now you've got a problem. Something that used to move doesn't move well anymore. Here's a picture of how wound repair happens. This is sort of any kind of tissue you can think of. It could be a ligament, it could be a tendon, it could be a muscle, it could be an organ. There's an injury and there's a tear in the integrity of the cellular structure. Fibroblasts, which is an immune system cell, arrive on the scene. They start spitting out collagen fibers. Connective tissue is made of collagen. The collagen starts to stick and starts to repair the tear in the tissue. But as it heals, it shrinks. And now you've lost functional length in the original tissue, so it doesn't even act like original tissue anymore. This is the limitation of scar tissue. It doesn't act like the original tissue in its functionality. Now it's sticky, stuck, layered, scarred, and stiff, and it doesn't move well. And fluid can't get in, information can't get in, waste can't get away, and now the cells start to exhibit strange behavior, less functional behavior. Does that answer your question?
Yes.
Okay, great. Okay, let's keep going. Adhesions and inflammation. So people think, well, yeah, it's obvious. If you get a surgery, there would be a scar. But what about if you have pelvic inflammatory disease? What if you have an STD? What if you have a bladder infection? Infection creates scar tissue because infection creates inflammation. And inflammation changes the kind of collagenous response in the local ECM. If you have chronic inflammatory problems, let's say you have some kind of autoimmune disorder, or you have endometriosis, let's say, that's going to be a chronic ongoing inflammation environment, and scar tissue is going to form automatically. The body lays down fresh layers of collagen every single day. Now, is that collagen going to be healthy, like the picture we just looked at, or is that collagen going to be adhesive? And the adhesive quality of the collagen is dependent on the inflammatory environment within the body. These are the different kinds of causes of inflammation: infection, injury, illness, sports injury, pelvic inflammatory disease, bladder infections, STDs, colitis, IBS, inflammatory bowel syndrome, IBD, inflammatory bowel disease, benign prostatic hypertrophy, or BPH, which affects a lot of men as they age, and appendicitis. But then there's structural stress, compression of abdominal organs caused by distortions in postural alignment. This is an example. Walking around like this, right here, what's getting compressed? Oh, my gallbladder, my pancreas, my liver, and my spleen are getting compressed by this little collapse here below the sternum. The minute I stand like this, I've taken away that structural compression, and I'm not squishing the life out of the collagen that surrounds the organs, creating a scar problem that's based in posture. Endometriosis and polycystic ovarian syndrome are causes of scar tissue. By definition, PCOS is an adhesive disease. That's what makes the cyst form on the ovaries. The ovaries should be popping out eggs through the ovarian wall. And PCOS means there's so much inflammation that now the ovary is glued to the peritoneum. That's the bag that holds the guts. And it can't operate. It can't function properly. The true cause of PCOS is insulin resistance. It's that you can't process all the sugar that you're eating. You're creating an inflammatory fire. That inflammatory fire is growing adhesive tissue, and that's shutting down ovarian function. So that's a kind of working backwards to understand how it might be reversed. And of course, the surgeries, C-sections, episiotomies, appendectomy, ectopic pregnancy removal. If you've got a pregnancy that's developing in a fallopian tube, that must be removed. Otherwise, it's potentially fatal. Cervical tears and conization. A lot of people are aware of HPV, and HPV changes cellular expression in the cervix. So people have biopsies or LEEP procedures to take care of their HPV, but that creates scar. And when it's time to have your baby and the cervix can't dilate, sometimes it's because there's scar tissue in the cervix that prevents its dilation, which leads to emergency C-section, which leads to another scar. You get my point? Okay. Yeah, I know. It's a lot because this is what happens to people. This is what happens to women. And people wonder why women are having problems finding their desire after childbirth. Take a look. This is part of it. Yeah.
So one of my friends, I'm not sure if she has endometriosis or PCOS, but she is also reporting pain while having sex. It's like, what is she supposed to do?
Okay, if she has sexual pain, the first thing to do is start looking at it more holistically. Now that this information is out here, guess what? This is going to be YouTube. She could watch this YouTube, and she could start to say, oh, gee, yeah, insulin resistance, that's a factor in my life. I know it is. I know my blood sugars are high. What can I do about that to change that? Oh, yeah, that sports injury. Oh, yeah, I had that surgery. All of these elements need to be looked at holistically. So the good news is I'm training people in this kind of holistic understanding of scar tissue in scar tissue remediation trainings that happen at this point offshore because it's too complicated to teach hands-on, hands-in work here in the U.S. because of scope of practice laws. I don't want to limit the people I train to licensed professionals. I want to train people who want to learn, and I have the ability to teach them in the UK, in Australia, in Canada. Not so much here, at least in the state of California. So I'm starting to train people to look at scar tissue holistically, ask the right questions, and get to the bottom of the problem. So people don't keep spinning around in circles waiting for relief when they're actually, no one asked the right question to get to the bottom of their particular problem.
Do you get a lot of referrals from doctors, gynecologists?
Not yet. I think that's going to change, though. Yeah. Yeah, that's why I'm out here talking to you all, not because I want your referrals, but because I want your understanding. I want your understanding so that you know that sexological body workers are available to do this work because it's extremely specific, extremely unique, and uniquely effective. It gets the job done because sometimes you just need somebody to get in there and work the tissue, and a gynecologist doesn't really have time, nor do they have the training to do this kind of work. And physical therapists may have the training, but they often don't have the hookup to the arousal piece of it, so you don't ever have that conversation. They are not trained to deal with an emotional release on the table when that happens. They don't know what to do with that. And unless you understand the integration of the emotional piece, you can't resolve the scar completely. Yes?
One problem with gynecologists and PTs is that they're trained to understand, or they're trained to rely on research and evidence-based treatments, especially when it comes to trauma, and so, or psychological issues, and so they're recommended to do CBT, and that's like a barrier that I'm trying to work through with these medical professionals of informing them about these types of things because their only referral is go see a CBT therapist. And so we kind of have to inform them of this kind of stuff. Unfortunately.
Yeah.
They don't refer to things that don't have evidence based behind it.
Yeah, and I live for the day when this is included as part of evidence. Right now, people aren't even asking these questions. And this is pure, it would be so easy to design studies because now we can see scar tissue. If you can visualize it, you can measure it. If you can measure change within a single session, hello, there's your evidence base. Yeah, so with 4D ultrasound, you can absolutely change how much, you can track how much fluid the connective tissue is holding and show change within one application of hands-on therapy, how the connective tissue has changed its configuration. So this study is just waiting to be done. Hello, grad students out there looking for something to do? Yes. Okay, finally, perineal tears and repair during childbirth are going to create adhesions and potentially inflammation, and of course radiation therapy. Folks who have cervical cancer or anal cancer or prostate cancer may get radiation therapy, and that radiation therapy certainly does create adhesions and painful scars in the pelvic floor. Here's some examples. Here's a woman who's fallen on her tailbone, and you can see now the tailbone is misaligned. It doesn't hang straight down from the bottom of the sacrum. Now it's pointing in. Here's a picture of what happens when that tailbone points in. It's pointing in, and it's impacting the cervix, and now adhesions are growing, fixating the cervix. The cervix is supposed to move during arousal. It's supposed to, the uterus is supposed to, if this is the vagina, this is the cervix. Here's the round ligaments of the cervix, of the uterus. They actually have muscle tissue inside. They pull the uterus in a new position, which changes the position of the cervix. What is it doing? Is it raising or lowering? Raising, right? Out of the way of what? Incoming penetrating objects. That means relief from cervical battering. Women who've had C-sections, happens all the time. The scar tissue from the C-section crawls down the front of the uterus, fixates it to the vaginal wall. Now that uterus doesn't move anymore, and women start complaining about sexual pain. I used to love deep penetration. Now I can't tolerate it. My husband thinks he's doing something wrong. He doesn't want to hurt me. Now he's pulling back, and we don't know why, but it just hurts. You know how long it takes to fix that? This long. Done. Castor oil, finger around the cervix 2 or 3 times. Those adhesions are so delicate and so easily changed. Anyone could do this. Every gynecologist should do this. It should be part of your postpartum checkup, especially if you've had a C-section. Not only at 3 months, how about 6 months? How about a year later? Find out, ask the question, do you experience cervical battering now in your sex life that wasn't present before your C-section? How long did that take, right? How long does this take? No time at all. And a woman's out of pain. And then she's having meaningful intimacy with her partner, and there aren't the restraints in their sex life that may be there if she's having pain. And, you know, a picture of how adhesions in the abdominal region create postural distortions here in this elderly gentleman on the right side of the screen. Pictures of episiotomy. In the US, most episiotomies are done in the midline, which is a big problem because there's a huge connective tissue bed called the perineal body right in the middle of the perineum. That incision will impact what? The working of the anal sphincter, making it more likely there'll be tears, fourth-degree tears into the anus and even to the posterior anal wall. In Europe, it's more common to have a medial-lateral incision. This is a better place to have an episiotomy if, in fact, you need one. And the efficacy of episiotomies is being largely questioned these days. People are not convinced. There's still some countries where they're standard of care. That means every woman who gives birth gets an episiotomy. In Trinidad, I was speaking to a midwife the other day working there saying, all women get episiotomies in our hospitals. In the US, not so much, because thank God for evidence-based medicine. There is no evidence that episiotomy helps anything when it's given on a routine basis. If it's given on an as-needed basis in order to prevent a severe tear, that's when you use an episiotomy. But for everybody, not so much. We don't need episiotomies. They do leave scars, and when the scars are in the midline here, where the conception vessel and governing vessel meet, that's going to distort and destroy your energetic system. Your whole meridian system is based on the continuity, for people who went to the shiatsu school, between the central line of the body in front and back. Its meeting place is right in the middle of the perineum. Episiotomy will destroy that. You can see here is a episiotomy that is going, it isn't just on the skin level, it goes all the way back. You can feel episiotomies and the scar going deep in all the way back to where the cervix is fixated to the back of the vaginal wall. So these scars can be in the vault, in the floor, on the sides, and severely affecting that cervix and its behavior, not to mention creating adhesive tissue, sticky, painful, tight, and pinchy sensations during having sex. Then there are different kinds of abdominal approaches. Here's a typical fan and steel incision. That's a C-section. Here's a vertical incision that you might see in an ectopic pregnancy removal. Those leave all kinds of adhesions that happen, then grow throughout the whole intestine, and then create intestinal blockage, which is deadly. Happens a lot to older people in their 80s. Their intestines kink up and block up because of adhesions. So this is something we could be working with castor oil packs on the abdomen post-surgically. A simple thing to do. Anyone could do this and actually increase their chances of having guts that aren't stuck together with scars. And then finally, this is a picture of sexological bodywork, a gloved finger in the vaginal space, working in this case with the G-spot. The G-spot is right at the vaginal vault, and G-spots are famous areas for people to accumulate scars, often from episodes of poorly lubricated sex in the beginning of somebody's sex life. I'm not going to ask you to raise your hands, but you all know what I'm talking about, I'm sure. You're less than lubricated. You know, a lot of friction. What's it going to do? It's going to grow a thin net of adhesive scar on the G-spot. You want to know why the G-spot is so hotly contested, is whether it exists and what it does and how it feels. It's because half the women in the world have scar tissue on their G-spot and cannot feel what it does. And when you finally work through that scar tissue, emotionally and physically, wow, it's a whole new world. Not only the clitoris is no longer the center of your sexual universe, now the G-spot can come out to play too. So understanding that scars are a huge inhibition of sensitivity in this area could be a motivator to get in and do some exploration at a personal level. Okay, I'll take questions if anybody has any left after the...
So can you just, I know there's like 2 seconds, say anything about people getting gender reassignment?
Yes, so gender reassignment surgery. What I want to say about that is what people need to know, particularly if they've gone male to female, is that there are still pleasure centers left in their new vagina, and you need somebody who knows how to, the territory, to get in there and find where those places are and hook the recipient up with their sensation. Because a lot of times there's this sense of, oh my God, I used to know how to have an orgasm and I don't know how anymore because everything's different there. But you can feel the erectile tissue. It's still there. It's still there, and it can be pleasured if somebody who knows how to do it gets in there to teach. So people often have to learn how to use their new configuration effectively. Now, when we're talking about female to male, there is often breast removal, and that's going to create a lot of scar tissue in the chest, which is going to impact breathing. And if you can't breathe well, then it's hard to generate the energy for a sort of full sexual trajectory of arousal. So someone needs to get in and work the scars in the chest where the breasts used to be. That's what I have to say about gender reassignment, is that it can be enormously facilitated by someone who knows how to palpate and is familiar and comfortable, has scope of practice to do this, and work directly with arousal as an educational experience for the person. When there's nothing at stake, and they're in a relationship and they're not performing adequately sexually, their relationship could be at stake and they may not feel comfortable, but going to a professional can make it easy. Yeah. Other questions? Yes?
What's been your experience with the receptivity of scar tissue, like over decades? Thinking about older people or even people our age who had surgeries when they were really young, or do you find, I mean, have you, it's like, I want to say, have you ever seen a scar tissue that wasn't receptive, or is it just a matter of?
It's a matter of going in and working with it, being patient, using castor oil. I have worked with scars. It's not that you can, it's not that you're too old. It's that sometimes when the scar tissue is old, you can try and work through it too quickly. And the older the scar, the more patient you have to be to make a permanent change. So it might, instead of taking 1 or 2 sessions, it might take 10 or 12 sessions to make it permanently more soft and malleable. I've worked on women who had their children 50 years ago, still having painful sex, and resolved their painful sex 50 years postpartum. It's possible. But it takes more than it would if it were 50 months postpartum.
And is there any difference, well, I'm sure there's a difference, but is there any are there any universal differences between internal scars and external scars?
What I would say is that internal scars are easier because the uptake for the active ingredient in the castor oil is so much more efficient through the mucosal membrane because there's fenestration, there's windows, spaces between the cells so that racinoleic acid can be absorbed deeply, rapidly, profoundly with just a little bit of encouragement. Whereas if you're working on a C-section topically from the outside, it can take longer because skin is a less permeable barrier. Anything else?
You mentioned male to female genitalia, but what about female to male genitalia?
Female to male is a little bit more complex because it depends on the nature of how that surgery was carried out. It's about finding what feels good and utilizing what feels good and taking advantage of the neuroplastic abilities of the body. In other words, find what feels good and reinforce. Reinforce and use plenty of lubrication. Reinforce and find other things that feel good that can be layered together with trying to introduce sensation into a newly formed phallus. For instance, there's a lot of approaches to female to male in terms some people just will free the clitoris. There's a suspensory ligament that holds the clitoris from being its full erectile capacity. Sometimes that's cut, and that then becomes the de facto phallus. Then there's less to do because it's still a clitoris and it's still got its full complement of neurological input. But if it's a constructed phallus, that's going to take a little longer, but it doesn't mean that it can't happen. There are people who are paraplegic that can still be orgasmic having their thumb stroked because they've taught themselves how to develop that acute sensitivity. Any other questions? Okay. Thank you so much for your attention. Yeah.